We are strong in the face of struggle, devoted in times of nurture, banded together to persist, torchbearers of hope. We know pain, but we are determined, resilient survivors.
This is our calling to care, to heal, to serve, to leave things better than we found them, bring health to our people. We are the next movement, empowered and ready to rise to greater places, lifting us all. We are healers. Join us.
Good evening. I'm Nutan Vaidya, Senior Associate Dean for Academic Learning Environment in Chicago Medical School. On behalf of Chicago Medical School and Rosalind Franklin, University of Medicine and Science, it's my pleasure to welcome you all to this evening's seminar, Native American Wellbeing, Health Disparities and Solution. It's hosted by Office of Excellence in Diversity and Inclusion with support from Creating Pathways and Access to Student Success Foundation. We are delighted to be hosting three exceptional physicians tonight who will speak to you on this critical topic. Thank you, Dr. Charity Bishop, Dr. Donovan Williams, and Dr. David Wilson for taking time to speak to us tonight. Additionally, thank you to those who planned this evening's event and made it possible. In Chicago Medical School Office of Excellence of Diversity and Inclusion, I want to thank Dr. Mildred Olivier, Assistant Dean for Diversity and Learning Environment, Dr. Carl Lawson, Interim Director of Learning Environment Diversity, and Hector Rasgado Flores, Director of Diversity Outreach and Success. From the Rosalind Franklin Office of Diversity and Inclusion, thank you to our colleague, Dr. Heather Kind-Keppel, who is the Executive Director for Diversity and Inclusion and has a faculty appointment in Chicago Medical School. Dr. Kind-Keppel will be moderating our event this evening. I will turn this over to her at this time. Dr. Keppel.
Thank you, Dr. Vaidya. So Dagon, which means welcome or peace in my native language. It's really important that we recognize the land that we occupy. This land was here prior to colonists coming and was occupied by others than ourselves. And so the Chicago area is located on ancestral lands of indigenous nations, including the Council of the Three Fires, comprised of the Ojibwe, Ottawa, Potawatomi nations, as well as the Miami, Ho-Chunk, Menominee, Sac, Fox, Kickapoo, and Illinois nations. One thing that I continue to talk about as I started at RFU is that to remind people that Chicago is has one of the largest urban Native populations. This evening, I am joining us from my home in Kenosha, and I am a guest on the Potawatomi lands because this is not my ancestral home.
I think it's important to at least ask Native American patients whether or not they are seeking any traditional types of medicine, because I know for me, I remember I had a sore on my leg when I was little, and I went to the dermatologist, and they scraped and they pricked and, gave me ointment and everything, but nothing happened. It didn't help it. It was still hurting. Nothing got better. And so as a result, I ended up going back to the medicine man that I usually went to at the time. And, I never question whatever he gives me. I have faith in it, and I trust that he's not going to give me anything that's potentially harmful. And so I used it, and it got better within a week. I think as a Native American patient, I'm reluctant to tell my doctor about seeking alternative treatments from a traditional healer or medicine man, simply because I feel as though the physician doesn't want to hear it, doesn't care, is like, has the attitude of whatever, that's your hocus pocus bull medicine. And, if you want to go down that road, more power to you. But I'm telling you that my medicine is superior, and it's my medicine that's going to get you well. I do trust my medicine man more than I trust my primary care provider in the hospital or in the clinic, just because the things that the medicine man give me are natural. And like I said, I've been using them ever since I was little, and every remedy that he's given me has worked. Therefore, he's got a pretty good track record, and I don't see any reason why I shouldn't stop going to him.
So it is my great honor to introduce our first panelist this evening. Dr. Donovan Williams is a Navajo physician. He currently practices as a complex care internist at the Minnesota Health Fairview Clinic in Eagan, Minnesota over the past year. He is a clinical assistant professor in the Department of Internal Medicine at USD Sanford School of Medicine and practices as local hospitalist with the USD Sanford Medical Center in Sioux Falls. He's been an assistant dean for diversity and inclusion at the USD Sanford School of Medicine from 2017 to 2020, prior to moving to Minnesota. He received his BS and MD from the University of Arizona College of Medicine in Tucson, Arizona. He pursued an internal medicine residency at the Good Samaritan Medical Center Veterans Affairs Hospital in Phoenix, Arizona as well. He is a member of the Association of American Indian Physicians. Dr. Williams has experience in mentoring Native American medical students, advising Native American high school students and undergraduates regarding pursuing careers in medicine and healthcare professions. Thank you so much for doing that. He loves to fish, lives with his wife, Dr. Valerie Norris, who is from the Red Lake Ojibwe Reservation, completed her pediatric residency in Sioux Falls, and enjoys time with their 3 dogs. Dr. Williams will now talk to us about the disparities in medicine perspectives from a Native physician. Thank you so much.
Hello and good evening, everybody. I hope you see me. It's always a little odd in determining feedback on Zoom meetings, but I did want to share a presentation. Let me pull that up onto my screen real quick. Okay. So again, I'm Dr. Donovan Williams, originally from Arizona, but I usually, when I introduce myself, because I'm Navajo, we usually introduce ourselves by clans. So I'll do that now. So Tkachitni Nchle, Debetlejina Bashishchin, Kia Ani, Dashiche, Ado Tsetes Kishni Dashinala. And we as Navajos, we usually refer back to our clans in reference to our relations as being Navajo. We usually have 4 clans. And they're a bit prioritized, such as the first clan I have is the Red Running Into Water is my mother's clan, and my father's clan is Black Sheep. So in a sense, I prioritize my relations to my mother's side of the family over my father's side of the family. And so in that way, we have more, I guess, thoughts towards prioritizing the mother's side of the family more. My secondary clans, the Towering House clan is my maternal grandmother's, and then my last clan is the Red Rock, and that's my paternal grandmother's clan. So a lot of this is more reference towards kind of the mother side for the clan systems. I just wanted to share that as an introduction, and you may hear that from people who are Navajo from time to time. Wanted to introduce a little bit beyond just a small introduction. I'm originally from Arizona. I grew up mainly in Flagstaff, Arizona, in the Ponderosa National Forest area. and there's a picture of the San Francisco peaks on top. That used to be what my view was when I was growing up. I also grew partly on the reservation to an area called Sand Springs and an area called Talani Lake. It's kind of interesting that a lot of references to water, although in these areas, there's not much water in those areas, but there used to be. But I did grow up on and off, mainly on weekends when I was growing up. My dad was a carpenter growing up, and my mom was mainly an at-home mother. And so we did enjoy when we had to go, out of Flagstaff. I would categorize it as a suburban city. I don't know what the population nowadays is, but I still consider it a suburban area. What I wanted to bring out today, I think, is just context of living. I think when we talk about health, I usually keep the context of where somebody is living, thinking about resources. As a physician, we're trained to kind of understand disease processes, kind of physical and chemical processes in the body, but also understanding some of mental health when we go through our training. But what I've learned outside of my training and learned through residency and beyond now as an attending is that the importance of living conditions, someone's economic status, educational backgrounds, belief systems, access to healthcare, food access, and then some historical policies that impact kind of a group of people also impacts health. I think keeping that in mind on a daily basis is a lot of what I concentrate on, trying to identify barriers in our complex care clinic. Along with my role in that clinic is to concentrate on medical decisions with our team. But keeping that into context, when there's insecurities in any area of these social determinants of health, it does impact care. We see that a lot. And so identifying and working on strategies to go beyond the boundaries we try and do in the clinic, but those are important things. I think for today around Native American health and my background, I wanted to bring across a little bit of the historical policy or historical contexts. There are not a whole lot of studies when it comes to Native American populations. However, there are some. If someone is not familiar with the concept of ACEs or adverse childhood experiences, they are something that I think was initiated in the Bay Area of California. I can't remember the year, but it was a look at does the impact of abuse or neglect, what you see on the left side of your screen, these adverse childhood experiences, does that impact health and disrupt health or even early death? And I think what they initially found in those studies were that if you had two of these experiences in childhood, it can impact health later on in life. It can impact social, emotional, and cognitive development, and also impact chronic, the probability of having a chronic process later on in life that may include issues socially, like with substance use, or other processes like cancer or diabetes. And for Native Americans, there at least was one study that looked at this. It seems to be that Native Americans have 2 to 3 times higher risk of ACEs compared to non-Hispanic whites. I wanted to bring that up just because I wanted to talk about context and living. When in the hospital or in the clinic, oftentimes it seems like we're making decision makings for patients themselves, but you got to remember that the patient in your interaction is not the only world that the patient lives in. They live in a community. They're not just disease carriers. So those are things that just to keep in mind. Plus, the added complexity is working within the system that you tend to function. What is the access that the patient has, insurance, those kind of things, and then on top of that, how are you able to work with a patient in general? So, kind of in a Venn diagram, just keeping context in mind is always important. Native Americans in general, there are 574 federally recognized tribes in 35 states currently. Each tribe is ethnically, culturally, and linguistically different. So there's a saying: you visit one tribe, and you visited one tribe. There are a lot of tribes and customs, protocols that people will live by. The population size of Native Americans isn't that much. It's about 0.9% of the population. I think this was off of the census of the 2010 census. It's interesting that a lot of natives are living in urban areas these days, but there are a good portion of patients that live on the reservation. It's a young population. About a third of Native American people are under 15 years old. There's a high rate of poverty depending on where people are living in urban areas or in reservations that may be that have poor economics, and that poverty rate varies from tribe to tribe. There have been some studies in educational gaps even as early as kindergarten. However, there are also the other end of the spectrum where there are professionals. It's estimated around 10% of the population of natives who do have a graduate or professional background. Talking about context, historical policies, just a couple points I wanted to bring out in this slide. In the early 1800s, a lot of it was the policies that were in the 1800s were around how do we were efforts in assimilation or removal off lands. It's probably the theme that was going on in the 1800s. I think one big impact is the era of boarding schools. It was an impact of trying to assimilate kids. There was one quote saying, "Kill the Indian and save the man," which was stated by Captain Pratt at the Carlisle Indian School in Pennsylvania. Basically trying to suppress, I guess, native cultures and trying to assimilate into cultures that were not their own back then. over time, lands have been taken away from Native peoples. It's not just the land, but what goes with the land. It involves food resources. It involves, where people may practice religious practices. Are there, migration camps that people may have traveled in the past? All those things have been impacted over time to where now we recognize more places in reservation lands. Boarding schools, a few notes about that on some of the experiences. A lot of people reported loneliness, feeling like they had been abandoned from their families. The abuse was, at least what was brought out by interviews, were there were witness beatings, sexual abuse, abuse from older children onto younger children. So these abuses were sometimes learned and impacted somebody where they may have had abuse impact onto other family members later on in life. There was reports of diseases in a lot of boarding schools, including tuberculosis, trachoma, and other contagious diseases. Likely impacted some of the survival of kids in these boarding schools. Not everybody survived in these boarding schools back then. So I think some of these ongoing or historical events still impact people today. So I wanted to bring that up. Policies in the 1900s, I see there was an effort more towards restorative efforts in the 1900s, things like the Indian Civilization Act, where a Native person or an indigenous person can be a citizen of the U.S. In the 1900s, there was the establishment of IHS, or the Indian Health Services. I look back into references. It seems to be 1956, but I think there was some papers that I read. It was started in 1955 for IHS, but it hasn't been that long ago that IHS was established. Later on in the 1900s, there was finally an American Indian Religious Freedom Act. A lot of people will reference that in 1978, meaning that people were not allowed to practice their religion. I think that started like in the late 1800s, and it lasted for about 100 years. But in 1978, they were able to openly practice religion, depending on what tribe you came from. So I see 1900s as a little bit more restorative, a little bit more positive, but still some of the historical references. Talking about resources, this slide kind of talks about per capita. This is a slide referencing in 2015 that the expenditure for somebody who had IHS care only had about $3,136 per year. Compare that to kind of the national health expenditure per capita was around $8,500 during that year, whereas Veterans Affairs per capita was similar to 8,760. I wanted to bring out this slide mainly because of when we talk about health care and its access, it's always important to know what the resources are within that system to take care of patients. Historically, the IHS has not had a whole lot of funding. to care for the needs of the people. So a lot of mistrust people have found in talking to Native people, things like lacking confidence in specific providers, not being heard, not feeling like they're part of the decision making, and less time for creating relationship building has been reported. A lack of confidence in the biomedical healthcare systems has also been mentioned. With older populations, I do hear the thought was that you go to the hospital and people die in the hospital. Yes, that's true, but I think having that mentioned by a patient, I've heard myself, and when I've taken care of patients in the past. Some people feel a system of exploitation, testing for different studies for follow-up, and then there may be history of personal history, familial history, or community history that reinforces stories from experiences from the past. So, in all, there are some mistrust issues with Native peoples that can come up. Talking about disparities, it's no, I would say it's not a surprise to hear that there are disparities for Native peoples, and it's across many different disease processes. I think that what to also bring out is that Native people are dying earlier. Deaths before 45 tend to be higher among Native peoples compared to African American populations and white Americans. So it's not really, to me, it's not a big surprise knowing that there are historical impacts on Native peoples through the U.S. to see disparities. As a provider, I have to keep in mind, are there unconscious bias? I mean, am I providing empathy? Is one question I ask myself. Am I listening to the patient? Am I trying to understand the contexts in which they're coming from? I also ask myself, what are the resources somebody has? Are these resources inclusive to everybody? Would be the question. Other things I keep in mind, knowing what my limitations are with my medical knowledge. I am not trained with everything. And so, I will tell people my limitations. I don't do procedures as an internist. But I do review medications very closely. Just knowing my limitations when I interact with somebody is always important for me. And then always remaining, what is my self-balance? Am I maintaining my wellness so that I can continue what I'm doing, continuing to basically provide a service for people? So those are things I keep in mind as a provider. For Native, there has been our revitalization towards looking at culture, and there have been a lot of qualitative reports that this is a positive thing. There's a quote here: "Our culture is protection." There are efforts in communities to try and maintain culture, including language, and it doesn't always reference to spiritual practice, but some of the principles within a tribe are efforts to try and maintain food. Maintaining that food practices within a tribe is also a big thing. So it's not all negative. I think there are positive things these days that are going on. But I wanted you to be aware of some of the context of where people are coming from. And I will leave it for that for now and move. I think Charity is up next.
Yes.
Dr. Bishop.
Oh, thank you very much, Dr. Williams. And please note, everyone, that if you do have questions, we will be having a Q&A session that 2 of our CMS students will be facilitating. And so it is my honor again to introduce our next panelist, Dr. Charity Bishop. Dr. Bishop is a physician educator and an assistant professor at the University of New Mexico and a board certified in family medicine. She is a member of the Acoma Onaha tribe of Arizona. She attended medical school at the University of North Dakota School of Medicine and Health Sciences and completed residency at the University of New Mexico, where she was a chief resident. She has experience working with Native American medical students in a variety of capacities for more than 10 years. She is currently working on developing a Native American health curriculum at UNM. Again, thank you, Dr. Bishop. She will be talking about increasing Native representation in healthcare.
Thank you and welcome, everyone. I'm excited to be here with you tonight. So again, I'm Charity Bishop. I work at the University of New Mexico. And a little bit about me. So this is a map of Arizona, and this is my tribal lands. So Gila River Indian Community along the Gila River. And my tribe has about 20,000 members, kind of located here between Phoenix and Tucson. And the history of our tribe. So our tribe was in the past very agricultural, very good at growing crops, which is hard in the desert, but they figured that out. And so that was a big way of life up until the late 1800s, kind of starting around 1870, more settlers were coming to the area and the water started being cut off. And so the river was not flowing as abundantly as it once was, and the people couldn't maintain their way of life that they always had. So there was starvation, and rations from the US government were brought in, things like refined flour and lard and sugar, and not foods that the people were used to. And so we do think that that has contributed to obesity and diabetes. Unfortunately, my tribe is known for having the highest rates of diabetes in the world, which is not a claim to fame that I am proud of. So here are some of our women and girls in their tribal regalia. So kind of loose cotton dresses is what we traditionally wear. And these baskets are a traditional craft, particularly the flat baskets. They use these a lot with things like mesquite beans that they would collect and eat. And I think this is important because people might have an idea of Native American kind of the tradition, I don't know, the kind of media, someone in one specific dress. And I think it's important to know that there are 574 different tribes, and each tribe has its own language and culture and dress and traditions. And over here, this is the governor of the community. His name is Stephen Lewis. And I didn't grow up on the reservation. I grew up kind of in the Phoenix area, about 20 minutes from the reservation, because my parents wanted us to have better educational opportunities. But my grandparents lived on the reservation, and we would go back and forth quite a bit. And my family lives there now. So Dr. Williams gave us a really good kind of broad introduction and discussion about kind of the context for thinking about Native people. And I want to talk a little bit more about education, and then focusing probably more specifically on medicine, representation in medicine. But to give you a little bit more context, internet access is not always readily available on reservations. I think about my mom, who just got internet in her home this year. And some places might not have electricity or running water. And so these are things that come into play when we're thinking of the health of our people. In thinking about education, there was a case in New Mexico actually that found that the state of New Mexico education system was not providing equal and adequate education to often more rural communities, and these included Native American communities. So there was a settlement, and there is action being taken to try to provide a better educational foundation to all children in New Mexico. Nationally, the high school dropout rate for American Indian and Alaska Native students is between about 12 and 14%. Here in New Mexico, unfortunately, it's a little bit worse than the national average. In 2018, about 69% of high school students graduated in 4 years and about 75 in 5 years. And you may notice I tend to use American Indian, Alaska Native, Native American, or Indigenous kind of interchangeably. And so if I do, don't be confused by that. That's just kind of habit. A lot of this research that I pulled uses American Indian, Alaska Native specifically. So, and then less Native people hold college degrees versus the American public in general. Just a little bit about nursing. And as Dr. Williams talked about 1% of our, the national population is American Indian, Alaska Native. Here in New Mexico, that number is higher. It tends to be about 11% of the population. And so it's kind of an interesting place where we do have more Native people living. For nurses, we make up about 0.4 to 0.6% of nurses in the US, and that represents about 11,000 RNs and 4,000 LPNs. Here you can see kind of a broader breakdown. So not quite representative of the population. Thinking about medicine, let me go back. This is looking at 2018-2019 data from the AAMC. And it shows that in that year, this is the American Indian, Alaska Native students who were accepted to medical school. And that represents 44 students, which is too low. And another thing to think about is this is looking at kind of graduation rates from 2002 to 2011, 2012. Just comparing American Indian, Alaska Native versus white students. As you can see, there's the biggest discrepancy in kind of completing medical school in 4 years. And it does improve by 6 years, but it's still much less than our white counterparts. And I also think about the 11% here that's like, what happened to these students? And I do know some students who kind of were students with me and maybe didn't pass step 1 and then kind of just didn't have like familial support or financial support to keep going. And so did not make it through medical school. And so this is something that is very concerning to me. And part of the reason why I decided to work in academics, because I think it's really important for students to have faculty and mentors who are reflective of them. This is looking at active physicians in 2018 by race and ethnicity. And here, this is American Indian, Alaska Native, about 2,500 overall. So as you can imagine, among full-time faculty, that number is even smaller, 0.2% in 2018, and that represents about 274 faculty members across all U.S. medical students. As I said, this is really important to me. One thing that we found is in working with students, a couple of years ago, students came forward and said to us, they did a project where they looked at the whole curriculum for UNM and tried to find what was taught about Native American health. And they did not find much, and they were very bothered by this. And so we started looking into this, and nationally, about 11% of US granting medical schools have American Indian Alaska Native health content. And so it is something that is not prevalent. There was last year a article in Academic Medicine that called for a Native health curriculum to be brought out across the board in an effort to address Native health disparities and health. So my research has been involved in, we created focus groups with Native and non-Native students, physicians, tribals, and community members, and we're doing more interviews with traditional healers and medicine men to see what elements of a curriculum would be most helpful for the students. And we have students who talk about their experiences in the hospital, that they felt that patients who they saw in the hospital were not getting the care that they needed, or there were cultural misunderstandings that impacted the patient's health. And so we are trying to focus on some of those things that are brought up. To me, the thing that makes me most proud is that students are still involved in this research right now. I have 3 second-year medical students who are working on this project with us, as well as faculty and staff at the Center for Native American Health at UNM. Some of our preliminary research findings, we've had students and faculty talk about the importance of people understanding the diversity of American Indian Alaska Native culture. And I think there's also an important thing that some people are super traditional with kind of Native spirituality, and some people are not. There's a whole gradation that comes into effect, and they thought that that was really important for people to know. We've also found that some medical school expectations conflict with American Indian Alaska Native values. I guess one example I can give from my tribe is that you're not really supposed to talk about your accomplishments. You're supposed to be very humble and not brag. If you were even just saying kind of like, oh, this is what I'm doing, it may be seen as bragging. And so that's been a little bit hard, because I think in academic circles, it's very much about this is what I've done and this is what I've achieved. And so kind of transitioning that. There was an interesting thing that came up too with our medical students, that they talked about the culture of we, that kind of like in a lot of Native communities, like the importance of the tribe and the importance of kind of putting the needs of your family and tribe above your own, or listening very deeply, and instead of kind of being the first to speak. And so some of these values are a little bit in conflict, and students have to adapt in medical school. I would say another example is, I think in a lot of Native cultures, we tend to see things more holistically. And for me personally, this was hard on multiple choice exams, because I could see I was kind of adding things in. this could be true of this, and this could be true. And so kind of trying to change the way I thought about things was really important for my success in doing step one and all of the things that we're required to do. We also are learning a little bit about specific desired physician characteristics in patients, in providers who are taking care of Native communities. We found trust is very, very important. And there's a lot of history of mistrust due to a variety of issues. And so establishing trust with a provider is something that's very, very important. There also in some IHS settings, there tends to be a lot of turnover. And so that makes it harder to build trust. They also really desired physicians who are empathetic and understanding and really have a desire to want to learn more, not kind of coming away from the idea of like cultural competence, just say like, even anybody, I as a Native person still have so much to learn about my tribal traditions and other tribal traditions, and that's something that's really important to us. So you might think, what can I do about this? If you have any students who are American Indian, I think one great resource for them is the Association of American Indian Physicians. Sometimes there might just be like one or two American Indian students in a medical school. And through the AAIP, they can meet other physician mentors or colleagues, peers. For me, my peers, my Native American peers in medical school were one of the strongest sources I had and really helped me to be successful in medical school. And so I think it's really important to have community, and that's one way to find that. I think about doing an away rotation in an American Indian community. If you're a student, maybe as an elective or as a resident, I think going and getting immersed is a really cool way to gain a better understanding. Mentor someone interested in medicine. And then I would lastly say, be an ally. If you see acts of microaggression, say something. So when I was a chief resident, I was going down to the emergency room to admit somebody. I was wearing my white coat. I was professionally dressed. I had my stethoscope around my neck. And the nurse came in and she was like, oh, good, the translator's here. The interpreter's here. And I was just thinking, what about my white coat and stethoscope? Makes you not see who I am. And so I think at the time, I didn't have faculty who were able to process that with me. So I just carried that around for a long time. So if you see something, if somebody tells you about something that happened, I think just validating that is something that can be really helpful and really supportive. So thank you very much.
Thank you so much, Dr. Bishop. And thank you for validating my use of we. It's always nice to hear from another Native that we do use we and validating that in a public space. So thank you. It is now my great pleasure to introduce our third speaker, Dr. Wilson. Dr. Wilson is the director of the KCI Institute and the Paul H. Casey Chair in Ophthalmology in the School of Medicine at Oregon's Health and Science University. He assumed the directorship of ophthalmology in 2005. Before becoming director of the Institute, he served as the director of the Department of Ophthalmology Residency Program and the Retina Fellowship Program, and has been with the Institute since 1988. Additionally, he is the director of the Christensen Eye Pathology Laboratory at KCI Institute. As Institute Director, Dr. Wilson provides the institutional leadership and the clinical and academic experience necessary to continue building a program of national prominence. Dr. Wilson is a member of the Verhoff Zimmerman Society, the Macular Society, and the American Ophthalmological Society from 2007 through 2014. Dr. Wilson served as the director for the American Board of Ophthalmology. Dr. Wilson received his bachelor's degree at chemistry at Sanford University and his medical degree from Baylor College of Medicine. He completed his residency in ophthalmology at OHSU, a research and a postdoc fellowship at the Wilmer Eye Institute, Johns Hopkins University, and a fellowship in retinal and vitreous surgery and ophthalmic consultants in Boston. Oh, I apologize. I'm not sure why I'm tripping on words. Dr. Wilson's primary area of interest includes eye pathology, clinic opathologic correlation of ocular disease, macular degeneration, gene and cell-based therapy, and ocular oncology. As director, Dr. Wilson limits his clinical practice to ocular oncology and eye pathology. Dr. Wilson also is Chickasaw. Thank you, Dr. Wilson, for being with us today and talking about equity in academic ophthalmology education and clinical care missions.
Well, thanks for that. Like has been said in my family, some things go on a little bit too long. I apologize for that excessive amount of material there. But as you mentioned, I am Chickasaw. I now live in Oregon, and as you'll see from my initial slide, it doesn't look like Oklahoma, but my grandmother actually grew up and went to one of those residential academies that Dr. Williams talked about. And so that's where I often really think of as my home. So I'm gonna go ahead and share my screen here, and where I am now is Portland, Oregon, and this is East, the beautiful mountain that overlooks Portland, and it's a wonderful place. And my talk is going to be maybe a little bit different approach, because I'm really quite interested in, as Dr. Bishop said, that academic health centers are a way that is really important for people in terms of their health care. But I am going to address it a bit from a policy perspective. And I want to preempt any thoughts that this talk might generate that I'm being critical of academic health centers, because I really see them as really the most innovative and the most altruistic places we give care. But I also think in this day and age, we really need to look at the structure of the way we do everything, including healthcare education, to make sure that it's not contributing to disparities. So please keep that context in mind. So I'll just pose this question at first. Does the structure of medical education lead to disparity in care? And I know this isn't something that really comes to people's mind initially, but you don't have to be around residency training too long before you start hearing questions or statements like, this would be a great teaching case, or I think this patient really should be on the resident service. And I think that reflects a culture in medical education that can be particularly damaging, because it does set up the notion that there are attributes of a patient that might put them into different categories. And it also creates a culture where once people leave an academic center, they view the world this way. And I think that's a culture that we really need to start addressing. And so that's really part of what I became interested in, and why I like to bring this topic up, because I think it affects all population groups, including Native Americans, but it's really applicable to all specialties and to all socioeconomic groups. So one of the first times I really started thinking about this was when, say, I'm in a surgical specialty, and one of the things that is increasingly done is looking at surgical outcomes. And so this is real data from some review of surgeons at the Eye Institute here that I was doing. And you can see that I've generalized this to where the measure is a surgical outcome, but there was a specific outcome. I just made it general. And the metric that everyone had agreed upon was that success should exceed 80% of patients. But you can see here that surgeon B was not infrequently falling below that metric. And you might think of many possible reasons for that. Here's a few. Maybe surgeon B is a fantastic surgeon and is given the most difficult cases. That would certainly be a reasonable thing. Or it may be that surgeon B was really needed to address some surgical limitations. But the actual reason was surgeon B was generous in permitting trainee experience. Now, that's not the finding in every type of surgical teaching, but it is possible that the outcome in certain maybe complex cases is different depending on the experience of the surgeon. So that led me to look more generally, and this again is actual data from the Eye Institute here, where we see roughly 130,000 patients a year. So it's a very high volume. So these aren't trivial numbers. And where I trained in Houston, where I went to medical school, there were very clear distinctions of a county and a private healthcare system. But actually in Portland, there wasn't. And I really like that about Portland, that they don't have distinctly different healthcare institutions. But in looking at mine, the one where I practice, I found that the services where there was a trainee involved, a resident, most of this is resident driven, but also fellows, there was a much higher percentage of patients that fell in or drawn from the Medicaid population than compared to the faculty population. So that type of distribution can occur sometimes structurally without us really thinking about it. And that's something I really want people to think about as they go through their training, and others that are involved in their training to think about how do we address this and perhaps change this culture. Now, this isn't super scientific, but it's something that you're certainly thinking, well, this is really an issue that has to be dealt with on a national basis. And that's partly true. I certainly don't deny that. But I really want to, by putting this together, wanted to put into context how things occur in the United States compared to other countries. So I have colleagues in these countries, so I asked them about how they do training within their healthcare system. So this is us here. Approximately 20% of healthcare is delivered by what I've termed academic medical centers, could include the VA, county hospitals, and other state medical institutions, whereas 80% of healthcare in the United States is given in community hospitals. So we have a distribution then of about 20% of our care occurring where a trainee might be involved, but again, it may not involve a trainee. In Australia, it's pretty much evenly split between a government program where all of the trainees are and a private system where approximately 50% of the patients are. So they've distributed their training across about 50% of their population. I'm going to come back to Switzerland in a minute. In the United Kingdom, as most of you know, there's the National Health Service, and 95 to 99% of patients are treated in the National Health Service and only 1% in private. In the National Health Service, trainees are potentially involved in all the cases. And there's really a culture developed there where patients expect that trainees will be involved in their care. And so I think that, you know, from what I'm advocating for here, that has a lot of advantage for us. Switzerland is very interesting. In Switzerland, you're required to have private insurance. So there's 100% of and this is a collaboration between government and private companies. And interestingly, they have a great deal of difficulty in getting trainee exposure during their training. And in fact, they often require sending their trainees to other countries to get their training. So that shows another potential problem in how a patient population has to be part of the culture of developing a good training. So I put this red box in to just reemphasize this is not, the result of an extensive evidence evaluation of the healthcare programs in those countries. So you might say, well, why bring up this topic now? I actually think that it's a topic that's important anytime to us as individual physicians and as we develop as professionals. But this is a time when we're really looking at changes in our healthcare system. And I think that all of those people involved should be thinking about this type of these policy considerations that can really have disparities in care, and as participants in an academic health center, I think we should be thinking about it as well. I think there are real equity concerns when we assign based on insurance type, the type of care that a patient is going to have access to, and that really leads to inequitable distribution of services. But an ideal outcome for this really is going to take a lot of people changing, including patients, because they really need to accept, as from my colleagues in the UK, patients in England do accept that they're going to be participating in a system where there is a rejuvenation of providers. Physicians really need to accept this cultural change as well, because, like I said, if physicians go out into the community and think that, well, this is the type of patient that should be on a teaching service, then that's really propagating something that I really don't think is the way that we want it to be. And of course, institutions really, if we're at 80% of the institutions not involving training of providers, then we really need to broaden our base so that we're having a greater number of providers available. So these are my conclusions, in that we really want to have our institution or the training of people integrated into all of patient care, that we shouldn't have different parallel courses of care, and that this is really important for us to have a long-term quality of care, because the type of physicians that we turn out of our academic health care systems really will be best in the long term if we adopt a different culture. So those are really the comments that I wanted to make. I really appreciate the invitation to address the group, and I look forward to your questions.
Thank you, Dr. Wilson. Thank you again to all three physicians for sharing your knowledge with us. I am going to turn it over to our Chicago medical students who will be facilitating the question and answer portion. So please let me introduce future Dr. Carolyn Cook, who is an M3, and future Dr. Javier Cruz, who is an M2. As you can see, I'm grinning ear to ear because we always want to speak the truth into existence, and I look forward to both of them being doctors. So please, this is your opportunity to ask questions.
And feel free to use either the chat function or the question and answer function. Or if you would like to speak, you can raise your hand.
Yeah, while we wait for questions to arrive in that chat box, I would say I have a question. Thank you, Dr. Williams, Dr. Bishop, and Dr. Wilson. I learned a lot from tonight's presentations. For me, my question is, as a student, as a future physician, how do we open the dialogue to patients who are wishing to use non-traditional medicine? You know, we are taught in medical school to be open and to talk to our patients about non-traditional medicine, but what does that actually look like when we're in clinical practice?
This is Dr. Williams. Is the question relating to non-traditional as outside of like the current healthcare based on biomedical science? Is that the question? Going beyond that?
Yes.
Okay.
Yes.
So I like the the video at the beginning where I think it was a student that was talking about going back to a medicine man about a rash. Thinking about that and thinking about where people are coming from, if they have a background with other healing mechanisms or other ways of health. I think for me it's important to ask what they would prefer. Some of the comments that I get from patients are, I don't like medicines. Is there something natural I can take? Or that's one comment that that sometimes is a screening comment for me to ask more questions, to ask about background. I think when I think about other circumstances, with some patients, they're a little guarded to openly talk about everything. I've seen that a lot with anybody in the hospital. I mean, anybody in the hospital are kind of guarded. They're worried about what's going on. And so really listening in on, is it really that their worry is coming out, or is it an expression that, there's not a trust, there's a trust issue maybe going on. And so going beyond that, if I were to address somebody who has a Native background, I also introduce myself as being Native. That's one way to break a barrier for me. I guess if I was non-Native, I would ask more, just curiosity questions on what they've experienced before, and then explore that further. That would be the one suggestion I would have. I think trying to stay away from assumptions is what I try and practice. I don't like to assume that somebody's living in a certain way. I'd rather kind of explore how living conditions or belief systems are with somebody.
I would just add that I think one thing that patients are looking for is your openness to discuss alternative care that they might be receiving. I don't know that they would be looking to you to provide that. And I think in the opening video, one of the messages that was being related was the negative response that she got from allopathic physicians about the care she might get from an alternative provider. And I think that being open to that is something that you can certainly express and ask if they are seeing other types of physicians. I know that in many medical centers now, alternative types of providers are part of the healthcare system, and that I think that helps for a patient to see that as well.
And I would say asking patients, like, is there anything about your culture or religion that might affect your health or that you want me to know about? Or even, I think sometimes asking patients, like, what do you think is going on, might prompt a little bit of, if they thought it was, you know, something that you weren't thinking of, could potentially help. But I think I would agree that being open and just asking questions, I think is one of the best things you can do.
If I can share a quick story, or no? So I remember as a child, I hit my foot on metal, and I literally opened it up as an adult, large enough where I should have had stitches. Like, it was a large gash. And I remember hiding it from my parents because I did not want to go to the doctor, right? I was so afraid of what would happen and they would do. And my grandmother, and all her wonderful perceptions, noticed what was going on. And she actually, clearly, she didn't have beyond a high school education, but she was able, and I'm not dismissing medicine, but she was able to take care of my wound in my foot in a way that I didn't have infection, because again, it was metal. And again, it doesn't negate allopathic medicine, but it does speak to, you know, there's ways to take care that aren't so traumatizing. Because as a child, that was my biggest fear, that my parents would see it. And how do we bridge those gaps? That's not a question, just,
yeah. I saw there was a question in the chat about how to nurture Native American students in medicine. And I really did it like Dr. Bishop's comment about how some of the things that we're asked to do to excel in medical school may not be as easy for some students as others. And so I think the one thing that we always need to do as educators is look for students that are not, or residents that are not putting themselves forward, not for lack of ability, but just their nature. And I think that it's very easy in medicine, as it's practiced in our educational system, to not excel to the extent you can. So I think looking for that type of personality and even personally addressing it is a very important thing you can do.
All right.
Okay, go ahead, Carolyn. Mm-hmm.
Yes, I'll move to a question in the chat box. It says, if we have small numbers of Native Americans in a given community, how do we train our medical students to better understand how they can build trust?
This is Dr. Williams again. I'm trying to think of concepts of what would be involved in trust building, and concepts such as empathy comes to mind, beyond just being sympathetic. Empathy kind of relates to trying to frame that it's all about the person rather than what are my priorities, you know. Because as an allopathic medicine physician, sometimes those thoughts conflict when I'm talking to somebody. Is like, you know, I have a recommendation on biomedical treatment plan, but these are my recommendations. Now, on the downside of that, there may be risks that can follow if you may be outside of recommendations in my mind. But when I'm thinking about empathy building, really kind of thinking about patient preference, their ability to understand what you're talking about. Number one, are the resources available? Number two, do we gotta go beyond, and do I have to reach out to somebody in the community, either through contacts of my own or social workers? Going back to some of my limitations again. So it's a skill. It is a skill that that goes beyond just trying to respect people when you work with them. It goes into the realm of trying to view where they're coming from, but at the same time, kind of making sure that there's an understanding that your guys are working together. That is probably the best way I would answer that question. It comes with time. It is a skill. It involves empathy. So that's just some input.
One comment I would make, this isn't so much individual patient to individual physician, but in Oregon, we have a lot of Native communities, and as we were trying to provide better coverage for eye care, we knew it would be important to go to the structure within the tribes and talk to the elders in the tribe, so that that was, creating trust through their own structure, rather than just here's a service we can provide for you. That I think was really critical in order to gain the trust of the people, to feel like the care was being given in an empathetic way.
And I think students having a little bit of historical context, like understanding that there were treaty after treaty after treaty broken, like understanding why that mistrust might exist there, I think is helpful. Just like going in like, this patient might not trust me. I think it's a lot about relationship. I do think medical students tend to have more time than maybe the attendings. So if they're able to spend that time and really listen to the patient, and I think that is one of the best things that can help try to build that trust. Another thing that's come up is like authentic communication. I think early in medical school, we teach students like, oh, you must feel blank. And sometimes the communication can get a little bit rote or rehearsed. And so I think just still trying whatever you can do to build that connection with the patient and build that rapport is really important. That as you're transitioning from the early years of medical school to actually the later years and becoming a doctor, like focusing on that interaction, not just being like a checklist in your mind, but being like authentic communication, I think is really important for building that trust.
One thing is, if you do encounter somebody where that trust may not be there, they may be frustrated, you should validate your understanding of their frustration. I think that also helps to build some trust, especially if somebody has let's say a mental health condition that impacts their organic health issues. Sometimes you have to work in the realm of their mental health goals, their care plan, their safety plan, before you can work on elements around organic health issues. So in that, I think one of the tools that is important is validating how the patient may be experiencing things.
All right, the next question we have is, what are some ways that non-Native providers can help to foster a safe, nurturing, yet rigorous environment for current and future Native physicians?
One thing I would say is like, give your students just a bit of time to answer. I'm somebody who just has to think for a little while. And I would say often in my medical education, people would just, I don't know, assume that I didn't know or assume that, make assumptions because I took more time and didn't just like immediately jump on the answer. So give people a little bit of time, I would say. I think I really found a lot of myself and other students like struggled with multiple choice. So specific strategies to work on that or address that. And another thing I would say is like just assuming all students are smart and hardworking, I think, and just kind of making that basic assumption for everyone. And I think there can be a lot of students questioning, like, do I belong here? How did I get here? I might be the first like person in my family to have graduated from high school or college. And so I think just a little bit of extra, I don't know, nurturing or grace or time, I think it can go a long way. Or just even interest in them, I think it can go a long way.
So Dr. Chatterjee comments, we should be promoting the concept of integrative medicine rather than alternative medicine if possible.
Yeah, Javier, I just wanted to follow up on that real quick. In the chat, I just put it as a little comment, but I think this notion of integrating different health systems into our practice is a very important one. And I'm glad to see that, you know, we're moving away from this notion that this is somehow alternative or complementary or something that is other, but really integrating it all into the care of the patient, into the holistic care of the patient, I think is what we ought to be promoting.
Well, I like that term. And I did happen to go over to Sirarat University in Bangkok, Thailand. And I can tell you, I really enjoyed the visit I had more with the nutritional aspect and the Thai massage than I did the more allopathic portion of the experience there. So I like that term integrative as well.
Are there any more questions in the chat area?
There's one question that says, what can we as healthcare community and research community do to establish stronger trusting relationships with Native communities, especially when it comes to public health outreach and research? I would say this takes time. And I would say reaching out to the community and maybe instead of saying, we want to do this project here, saying like, what is important to your community? What issues are you dealing with in your community? Because I think you'll have a lot more buy-in if something is community driven rather than this is my research, let me, impart it into your community. So I think it's hard and it takes a lot of time. And, in research, there's been trust issues and atrocities, I guess I would say, in the past. And so time and doing a community survey to see what they think are the most pressing issues and what they feel is.
I agree on the research. I think too, there's a lot of self-determination in that we are doing the research ourselves now. I think Dr. Bishop, you talked about Native communities and the gross negligence of research that's been done over the centuries. And I think it's imperative that in some ways we are the ones bringing that research home. So if that makes sense.
And I think once we get somebody who looks like us and we go to our own communities, we are more likely to ask those questions about our community, and we're in those communities asking questions other people may not even think about. So I think, I don't know how we build this pipeline in the Native American community. It seems to be difficult because the numbers are so small.
Difficult, Mildred, not impossible.
No, not impossible.
What it takes is is the will to make a change and to bring about sustainable change. Takes time, takes patience, takes resources, and connections, as you are hearing from our panelists tonight. Those connections, building that trust is critical before you start to make an impact and make a difference. I think that those are the baby steps that we have to take first.
I know Dr. Lawson has been working on the curriculum, and he has a question I think that could help all of us. Carl, do you want to?
Yes, and I'll unmute myself here. What do you recommend be added to not just our medical school, but any medical school curriculum to better equip future physicians to contribute to the well-being of Native patients?
I would probably, there's been some really good work done by Melissa Lewis, who's actually created Native health curricula for at least one medical school and is working in other places. So I would go, and she's like published specifically about creating a curriculum at the University of Minnesota Duluth, and outline some of those things that she's used. And I would say that I think it's a 2020 article in Academic Medicine about Indigenous health curriculum. I can find that and send that to Christina, if that would be helpful, and she could get that to you.
I would call out what Dr. Williams mentioned in his talk about social determinants of health. I think there's really wonderful literature on that. There's a lot been written by an author, Michael Marmot, who is a public health person. So I really think that we have not stressed some of what we know about the benefits of social determinants of health within medical school curricula, and I think we should.
I'm gonna add a little bit about what Dr. Bishop also said in her presentation. I know we're commenting on each other, but Dr. Bishop also mentioned that if you do have that time to immerse yourself into a community that's not your own, and it doesn't need to be always involving a Native community, but a community outside of your own. There's a lot of research that says that immersion experience actually helps to change perception and potentially impacts cultural competency rather than kind of a Socratic view of, getting a PowerPoint and maybe adding it ad hoc to your curriculum. I think having that immersion experience or background helps out a lot to understand and build those skills of empathy.
Thank you. Heather, do you want to?
Yes, we are at the 7 o'clock mark, and so I wanted to thank all of our panelists for being in community with us this evening and sharing your expertise and your own stories and narratives. We really very much appreciate that. But I also wanted to introduce the Dean of the Chicago Medical School, Dr. Chatterjee, and she will close us with some final statements.
Thank you very much, Heather. I've already been making my presence felt with my comments and questions, but I want to also thank everyone who is here tonight, all the panelists, especially Dr. Kind-Keppel as moderator, and our two students, Carolyn and Javier, who maybe could have been doing something else like studying because they're medical students. I'm always appreciative of the time our students take out of their study time to devote to these very important activities. So thank you, Carolyn and Javier, for doing that for us tonight. A special word of thanks also to Christina for doing all of the logistics and making this happen. This is part of a series of seminars actually that we have been holding addressing health disparities among marginalized populations. And we are very grateful to our panelists, Dr. Williams, who is an old friend. He's not old, I'm old, but a friend from South Dakota, and Dr. Wilson and Dr. Bishop for sharing your knowledge, your expertise, your wisdom with us tonight. You have given us much food for thought. There is much work to be done. And I just want to end by saying that we are all engaged in this work, and your guidance and help as we move forward is much appreciated. I would love to welcome you to our beautiful campus in North Chicago, and may that occur sooner rather than later. This is only the beginning of this relationship, hopefully, with all of you, and we certainly hope that you will come and join us in person sometime in the near future. I wish everyone a very good evening, and thank you again very, very much for being here tonight.